Okay, hello class. So we are going to cover today a pharma, genetics, immunology. Okay, of the only for the pulmonology section. Okay,
Okay, doctor.
first question. This question has two parts. Which of the following is the most likely cause of these patients? Increased anion gap. Okay, read the options for once. Then from top, start reading the question. 87-year-old man, nursing home resident, brought to the with a 2-day history of fever, vomiting, progressive lethargy, medically significant for advanced dementia and stroke, temperature elevated, blood pressure is 88/62. That means the patient is in shock, right?
The shock.
Okay.
Yes.
Septic shock.
And what type of shock? Septic shock. Why?
Septic.
Because its temperature is elevated. Okay. Coarse bronchi are heard over the right mid-lung area.
I can open the door.
Platelets are also elevated. Sodium is 140, potassium, bicarbs are 18, glucose 121, lactic acid is
Glucose is
also
elevated.
elevated. Okay. So we have done one question on septic shock, that the mechanism of action, how does the septic shock leads to the increased lactic acid. Okay.
The L, the sign.
Okay, why does
Go
the
and play.
lactic acid gets increased in the septic shock? Because the cells are no longer be able to use the oxygen to extract the oxygen from the arterial blood. And where in the cell oxygen is used in the mitochondria, and in the mitochondria where? In the electron transport chain. What is the other name? What is the other name for that electron transport chain? Oxidative phosphorylation. We are using oxygen, that's mean oxidative, to phosphorylate ADP into ATP. Okay, so oxygen is used in electron transport chain, and in septic shock, when there is vasodilation, the cells are no longer be able to use the oxygen in the electron transport chain. So electron transport chain is no longer be able to work in producing the ATPs. Okay, so the only source of ATP in that case is glycolysis. Okay, and for the glycolysis to keep on working, you need a constant supply of NAD plus. Okay, and where do we get the NAD plus? We get the NAD plus by converting a pyruvate into lactate. Okay, when the electron transport chain is not working, the only way through which we can regenerate the NAD plus is through pyruvate into lactate. In this manner, we regenerate the NAD plus, and in this way, the glycolysis is keep on running. Okay, even when the electron transport chain is no longer working. That's why the lactic acid started to get elevated in our blood. Okay, okay, so regarding the increased anion gap. Okay, let's come to the metabolic acidosis. There are two types of metabolic acidosis. One is normal anion gap and the other is increased anion gap. Okay, okay, whenever you are adding some acidic compound into the body, the anion gap is going to elevate it. Like in septic shock, you are adding lactic acid. Okay, so the anion gap is going to get elevated. Okay, okay, let me open it. Is it written in renal?
610.
Okay. In renal metabolic acidosis has two types. This is the formula of the anion gap. Sodium minus, we will add the other major anions in the blood, which are chloride and bicarbonate ions. Okay. Let's see the anion gap in our question. Sodium is 140. Chloride is 101 plus 18, 119 minus 140. The answer is 21. Okay. The anion gap in our question is 21. Okay. So whenever the anion gap is between 8 to 12, it is normal. Okay. When it is greater than 12, it is increased anion gap. Okay. Now see all the examples. Aspirin starts from glycol. In glycol, you are adding ethylene glycol acid. Okay. In lactic acidosis, you are adding lactate acid. In in methanol poisoning, you are adding methanol acid. In aspirin toxicity, you are adding metabolites of aspirin as an acidic compound. In renal failure, the urea is going to get elevated, which is also an acidic compound. In diabetic ketoacidosis, you are adding ketones, which are acidic. Whenever you are adding a new acid into the body, the anion gap is always going to get elevated. Now comes to the normal anion gap. Diarrhea. In diarrhea, you are not adding any new acidic compound. The only thing which is happening in diarrhea, you are losing bicarbonate ion. Okay, you are losing a basic compound from your body. You are losing bicarbonates. Okay. In renal tubular acidosis, you are not adding any acids. Okay, you are just removing bicarbonate ion in excess as compared to the acids. You are removing excess bicarbonate ions from your body. Okay. In Addison disease, in spironolactone, you are not adding any new acidic compound. Okay. So this is one way of knowing whether the anion gap is going to get elevated or not. Okay. So in septic shock, the lactic acidosis, there is lactic acidosis though. So the anion gap is going to get elevated. Okay. So what will be the answer in this question? We have solved a similar question like that in the previous ones as well. What should be the answer here? What is the most likely cause of the patient's increased anion gap here?
A.
The cause is the production of lactic acidosis. Okay, and why there is lactic acidosis here? Because the electron transport chain is not working. Okay, because the cells are no longer be able to use the oxygen. Okay, okay, remains lactic acidosis. Okay. End organ hyperperfusion leading to impaired tissue oxygenation and leading to a buildup of NADH during glycolysis shunting to pyruvate to glycolysis. Let's move on to the part 2 of this question. It is the part 2 of the same question. The patient is treated with intravenous fluid antibiotics. Okay, the patient. This is all the options. Okay. We treat the patient with intravenous fluid, antibiotics, and there is improvement of fever, leukocytosis, and hypotension. On the third day, temperature is 36.7, blood pressure is a 120, the vitals are normal. Okay. He is mildly lethargic and his voice is soft and breathy. Bronchi are still heard over the lower right lung. Okay, no, bronchi are still heard over the lower right lung. There is left-sided facial droop and hemiparesis from previous stroke. Okay, there is a stroke. Okay. Chest X-ray demonstrate dense air space opacity in the superior region. In the superior region of the right lower lobe. Which of the following underlying factor most likely predispose this patient to his current hospitalization? Okay. The new opacity is the same which the patient has before he came into the hospital.
No.
No, yes. The first opacity is at the lower right lung. Okay. Now he is saying the patient develops a dense air opacity where location is
Right lower lobe.
superior region, right lower lobe, and there is left facial drop and hemiparesis from the previous stroke. What is the most likely cause why the patient develops an air space opacity in the superior region of the right lower lobe?
Bedridden.
I think this
Any
is
guess?
aspiration.
Aspiration,
Aspiration.
pneumonia. Very good. And in which lobes aspiration pneumonia develops?
Usually in the middle or in the upper part of the
Lower
lower.
lobe.
It
Lower lobe.
depends on the position of the patient, actually.
I
Yes, it
think it's
depends
more
upon
often
the
in the lower lobe.
presence day after aspiration event in the dependent lung sentiment. More common in right lower lobe if sitting up,
Yeah, and posterior if laying down.
and right upper lung if lying down during the bronchial anatomy can progress to abscess as well. Okay. Risk factor: altered mental status, neurological disorders, dysphagia. Our patient is a stroke patient who has a left-sided facial drop and hemiparesis. And the location of the new opacity is in the superior region of the right lower lobe. Right lower lobe. Okay. Of the right lower lobe. Okay. Which of the following underlying factor? Okay, now tell me which would be the answer then in this patient.
Would it be?
Extended immobility. You are saying option number B is the right answer? Option number B will be the right answer if the diagnosis is
DVT.
DVT.
yes,
DVT.
yes. If the diagnosis is DVT, but we know our patient is not suffering from pulmonary embolism, which arises from the DVT. Okay, so option number B is not going to be the right answer.
UBC.
Okay.
E.
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 Yeah.
E is going to be the right answer because when you have a swallowing muscle dysfunction, you are going to aspirate the oropharyngeal contents into your lung, and the patient has a right-sided facial droop. He no longer can control his muscles of his facial muscles, okay, which is leading towards the aspiration, okay, aspiration of oropharyngeal or gastric contents. Okay, dysphagia. Okay. Dementia, stroke, aspiration. Okay, aerobic upper limb mismatch. Okay. Analysis of genomic DNA shows reduced IgE type switching. IgE type switching in activated B lymphocytes. The new medication most likely inhibits which of the following cytokines? Okay. Which of the following cytokine is involved in the IgE isotype switching? Okay.
5. Interleukin 5.
Interleukin 4.
TGF
I think
beta is involved
so.
in which? TGF beta,
Fibrosis.
fibrosis. Interferon gamma is involved in what?
It is a C.
Granuloma
Interferon
formation.
Granulomas.
granuloma formation in TB, in sarcoidosis. Okay, it is involved in. Interleukin 1 is involved in
Fever.
Fever.
Fever. It is an acute phase substrate which is involved in fever. Okay. Now there are option number B, C, and D left. You remember the drugs we used for interleukin 5? Rizalizumab.
Yeah.
Yeah, those are for interleukin 5 that are used against that are also involved in asthma, because we know that interleukin 5 is involved in asthma, but there's a
It's
trick
present
in
on
this
the
question.
eosinophils.
Yes, but there's a trick in this question. Analysis of genomic DNA shows reduced IgE isotype switching. Okay,
Yes.
the one interleukin that is in interleukin 5 is also involved in the asthma and IgE, but it is not involved in class switching. Okay. See, interleukin 5 is involved in stimulation. It stimulates the growth and differentiation of eosinophils. Okay, interleukin 5. Now see interleukin 4 enhances class switching to IgE and IgG. And in our question, what he is asking, which interleukin is going to get involved? Okay, in class switching. Okay, so now you know why the answer is interleukin 4, not interleukin 5. Okay,
Yes.
okay, it is not interleukin 5, but interleukin 5 is also involved in asthma, and because it is directly related to the growth of the eosinophils and the differentiation of eosinophils. And if you control interleukin 5, you can control eosinophils, and we know that eosinophils are the ones which are directly involved in asthma attack. Okay, but class switching is a function of interleukin 4.
Oh.
Okay,
But they mentioned, they mentioned that in class switching of hemoglobin A, interleukin 5 is involved.
enhanced class switching to IgA.
Uh,
And we are seeing reduced IgE isotope switching.
okay.
Interleukin 5 is class switching of IgA, and class switching of IgE and IgG is the function of interleukin 4. Okay, because he is asking in the question that which interleukin is involved in class switching of IgE, not IgA. Okay, if the question is regarding IgA, then you can select interleukin 5. Okay, am I being clear?
Yeah. It was a little bit tricky.
Yeah, it was a tricky question. Okay, so
What
that's why
page?
you should. Further testing shows a high chloride content in his sweat.
Cystic fibrosis.
Yes, very good. The
Yeah,
diagnosis is
cystic fibrosis.
cystic fibrosis. Four-year-old boy past 2 days, that is personally worsening them past 2 days, productive of yellow sputum. Recent infections, most common. Year ago, he was found to have bilateral local which was diagnosed with pneumonia, and his traditional medicine planted chest disease, bilateral local infections. Okay, so we know that the chloride sweat test is a very specific very specific test for cystic fibrosis, and the patient age is 4 years. He has recurrent chest infections and pneumonia. All of these findings uh, are telling that the diagnosis in this question is cystic fibrosis. Okay, now he is asking what abnormality occurs in the cystic fibrosis. Okay.
Is that post-translational processing of the transmate?
Yes, it is post-translational processing. It is written in the chemistry. Let me see this. Okay,
It's in 58.
58. Okay. So this is the pathophysiology in the cystic fibrosis. Cystic fibrosis contain the gene that is involved is CFTR gene. Okay, it encodes a ATP chloride channel. Okay, and when this gene is deleted, in on this gene, what is deleted? Phenylalanine is deleted at 508 location. The protein becomes misfolded protein. Okay, and there is improper protein trafficking due to which the protein is absent from the cell membrane. Okay, the protein is misfolded due to the mutation at the third base pair of phenylalanine amino acid. Okay, it leads to an impaired post translational processing. Okay, after the protein is translated into amino acids, the post translational processing, in which there is folding, there is glycosylation, that is improper. The folding is improper, and folding comes at what phase? In the post translational phase. Okay, abnormal post translational processing. The transcription is not affected. The conductivity, the main defect is not in the conductivity. The protein never reached the cell membrane. Presence, no. The protein never reached the cell membrane. With increased regulatory, no. So the only answer left with is option number A. Okay, CFTR. Improper folding and glycosylation of CFTR. Okay. Which of the following is the most likely site of action of the following drug? Which drug we are talking about? He has started on a trial of inhaled cromolyn. Okay. So the drug he is asking us the function of is cromolyn. And we know what is the function of cromolyn is?
It prevents mast cell degradation.
It prevents mast cell degranulation. Cromolyn prevents mast cell degranulation. Okay. And you can see here as well, cromolyn is inhibiting this degranulation phase. Okay, degranulation. Okay. In this photo, where the degranulation is occurring, is it occurring? It is occurring at point E, where the vesicles are releasing their granules outside. Okay, so at this point, the degranulation is occurring. So the right answer would be option E.
E.
Okay. Okay. Chromoglobulus intestinal. Okay. Okay. Point A will be the site of action of what drug? Point A.
Omalizumab.
Yes, the anti-IgE antibody, omalizumab. Point B. Which drugs acts on the nucleus within the nucleus?
The glucocorticoids.
Yes, steroids. Okay. Which drug acts at point C? Inhibits the conversion of arachidonic acid into leukotrienes.
Xylutine.
Yes, xylutine. And which drug will be the answer for option D? Leukotriene receptor inhibitor.
Montelukast.
Yes, Montelukast. Okay, Montelukast. Xylitol antihistamine. Okay, let's move on to the next one. Which of the following is the greatest contributor to the patient's pathological findings? Now let's first try to diagnose this patient. The autopsy findings are consistent with what diagnosis? With what
Bronchitis.
pathological disease?
Bronchitis.
Chronic
Yes.
bronchitis.
Acute, they are consistent with bronchitis because we are seeing they are thickened bronchial walls, inflammatory infiltrates, mucus gland enlargement. All of these are going to be seen in chronic bronchitis. Okay. Now comes to chronic bronchitis. Here it is. Okay. Hyperplasia and hypertrophy of mucus secreting glands in the bronchi. Metaplasia of pseudostratified ciliated columnar epithelium into stratified squamous. In this, on the autopsy, you are seeing thickened bronchial walls, mucus gland enlargement, patchy squamous metaplasia as well. Or both of these things are written in the first aid, right? So the diagnosis here is
B.
chronic bronchitis. Okay. Now tell me which of the following a risk factor is the biggest contributor in this specific scenario.
Smoking. Smoking.
Okay, if I say mining,
Smoking.
if I say mining,
No.
why no? Mining will be the risk factor for what disease?
Silicosis.
Yes, it will be the risk factor for silicosis. And we have known that it is not silicosis, it is chronic bronchitis. And chronic bronchitis, the biggest risk factor in this patient is smoking. And so if it is smoking, we know it is not asthma. Allergic is not the answer. It is not it's a genetic type of emphysema. It is not some type of infection. There is no neoplasia here. There is no silicosis. So the answer is behavioral, which is due to smoking. Okay? Tobacco smoking, thickened bronchial infection. Okay. First, try to diagnose the patient. Late inspiratory crackles. Inspiratory crackles are heard in restrictive or obstructive?
Restrictive.
In restrictive.
Restricted.
And there is digital clubbing as well. Dense collagen fibers, foci of proliferating fibroblast. Collagen fibers.
Fibrosis.
Yes, very good. Very good. Okay, so what is the diagnosis here?
It's the interstitial lung disease.
Pulmonary fibrosis.
Pulmonary fibrosis.
A, it is an interstitial lung disease or pulmonary fibrosis, idiopathic pulmonary fibrosis. Okay. See, there's interstitium is involved, lymphoplastic infiltrate, there's fibrosis. It is idiopathic pulmonary fibrosis, which is an interstitial lung disease. Okay. Okay, and we have discussed this multiple times. Alpha-1 antitrypsin involved in which disease?
Emphysema.
Pan-acinar emphysema.
Endothelian 1.
Pulmonary hypertension.
Pulmonary.
Interleukin 5.
It's asthma.
Eosinophils. It
Eosinophils.
causes the differentiation of eosinophils.
In asthma. Phosphodiesterase 4. Phosphodiesterase 4 inhibitors are used in which disease?
In pulmonary secondary, I think.
Pulmonary
secondary-
hypertension.
Erectile dysfunction as well.
PDE4, not 5. I'm not talking about
That is
PDE5.
PD5.
Yes, PDE4 inhibitors are used in asthma. Okay, PDE4 inhibitors, roflumilast is used in asthma and COPD. Okay, PDE5 inhibitors are used in pulmonary hypertension. Okay, okay. So, what is going to be the answer here? TGF beta. Okay, let's move on to the next one. So he is asking us which of these feature is going to be the last one to be removed from the respiratory tract. Okay, when you are observing the respiratory epithelium, which one is going to be the last one to be get eliminated? Okay,
Celia?
okay, let's see the photo. Okay, see this photo. Cilia terminate in respiratory bronchioles. Okay, this is cartilage. Cartilage is going to be absent at the level of bronchioles. You are not going to see cartilage at the levels of bronchioles. Okay, so cartilage is cancelled. Goblet cells and these are the goblet cells. Okay, and the mucosal cells are going to be get eliminated after the when they reach the bronchial stages. There is no longer be the so goblet cell, mucus glands, and serous glands. Okay, so you can see where even in the respiratory bronchioles there are some cilia. You can see some cilia here. Cilia are the last one to get eliminated. Okay, in all of the present options. Okay, so what will be the answer then?
B.
Cilia. Okay, cilia are the last one to get eliminated. We have solved this question before. Let's see if you people remember this question.
Yeah, we solved it.
Yes, we have done.
What is happening in this question? What is
It's
happening
the
in
cytochrome P450.
Thiophene
increases and
toxicity due to cytochrome P450 inhibition, like
and,
ciprofloxacin,
yes.
that.
Ciprofloxacin. Very good. Let's move on to the next one. Which of the following is the most likely triggered this patient condition? Okay, you have to find out which type of hypersensitivity reaction is happening here.
Yeah, this should be type 1.
What is happening in this patient? The patient is having a
Anaphylaxis.
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 Type
And
1.
yes, he has having blood pressure is 70 by 50, erythematous raised plaques over the skin and the face, bilateral expiratory wheezes. Okay, now we are sure that it is anaphylaxis. Anaphylaxis is a type 1 hypersensitivity reaction. Okay, and type in what will happen in type 1? In type 1, there is antigen cross-linking cross-linking preformed IgE on pre-sensitized mast cells, leading to the release of the histamine, tryptase, and leukotrienes. Okay, cell-mediated ones are the type 4. Antigen immune complex types are the type 3. Antibody-mediated are type 2, and anaphylactic and atopic are type 1. Okay. Antigen antibody complex, option number A, is for which hypersensitivity reaction?
This is true.
Antigen antibody complex is for
A complex is 3. Wait,
is for
Three.
3.
Three.
3,
It is
yeah.
for 3. Okay.
Yeah.
CD8 plus T lymphocyte.
This is
It's
4.
4.
4. Very good. Antibody dependent cell mediated cytotoxicity. Antibody
This
dependent.
is 2.
Type 2.
Very
2.
good. Okay, now we are left with option number D and option number E. Okay, which one is going to be the answer here?
D.
D.
Cell surface bound antibody linking to antigen. Okay, the moral one is going to be the option number C. A is type 3 and B is type 2. Okay, IgE cytotoxic immune complexes, and type 4 is T cells and macrophages, neutrophils. Okay. 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 37 progressive shortness of breath, dry cough, seasonal allergies, lungs at late auscultation, pulmonary infiltrates, hilar adenopathy. Okay, hilar adenopathy. In the histology photo, can you tell me what is visible?
These are the granulomas.
Non-caseating
Caseating
granulomas.
or
Non.
non-caseating?
Non.
Non-caseating.
No.
Non-caseating
Caseating.
granuloma. Very good. Okay. So, which
Sarcoidosis.
interleukin is
Sarcoidosis.
involved? Which interleukin is involved in granuloma formation? Which interleukin is involved in granuloma formation?
And these are the interleukin 12.
12.
A, in what is the name of the test we used for TB? There's a name of the test we used for TB detection. IGRA.
Repeat. IGRA, yeah.
IGRA stands from interferon gamma release assay. We also see granulomas in TB, and we made what interferon gamma there. So this will help you remember that interferon gamma is involved in what? In the formation of granulomas. Okay, and we also see granulomas in sarcoidosis. So it is not option E, it is not option D, it is not option B. It is option A, C, either or either is C. Okay. Now we have to select between A and C.
I think it's
It's
A because
It's,
CD4 involved. A.
it is A. Okay,
A.
CD4. Okay. In case it is then interleukin 2. Okay, CD. And do you know the function of interleukin 2? What is the function of interleukin 2? Stimulates the T cells. Stimulates the T cell interleukin 2. Okay. Interferon gamma is released by which cells? Th1 cells. Okay. And the 4, 5, 10, 13 are released by Th12 cells. Okay. So you can see in option number C, there is Th2 cell, Th2. And we know that the Th1 cells are the one which are involved. Okay. So it is going to be Th1, interleukin 2, and one more. That is going to be interleukin 12 as well. Okay. Interleukin 12 is also involved. Okay.
Doctor, what page is that?
It is page number 106 of immunology. 106. Okay. Okay. Interleukin 12 is also involved. Okay. Remember this as well. Interleukin 2 and 12. Okay. And Th1 is involved in the secretion of interferon gamma. Okay. Remember this as well. Which of the following methods would have been most effective in preventing this patient abnormal oropharyngeal findings?
I think this we have done it before.
So, and what is happening in this question?
No.
It's
Yeah.
oral touch.
Yeah, the patient has like steroid inhalers that cause
Inhaled
the
steroids, he is
candidiasis,
using inhaled steroid due to which, due to the local effects.
asthma.
Yeah, in
Yeah.
asthma, due to the local effects of steroid, we are seeing a oropharyngeal candidiasis. Okay, and that can be prevented by using either a spacer or a for oral rinsing of
Oral rinsing.
inhaler use. Okay, we have done this question before. But if someone do not remember, use a spacer or rinse mouth after use to prevent oral thrush. 36, woman, dyspnea, weakness. Mother died due to similar symptoms at age 42. Lung biopsy performed. There is medial hypertrophy, intimal fibrosis. In the diameter is very small. Diagnosis.
Pulmonary hypertension, primary.
And which drug is used in pulmonary hypertension?
Endothelin 1 inhibitor, that is bosentan.
Yes. Endothelin 1 inhibitor. Other than that, PDE5 inhibitors
Five, yeah.
and
Sildenafil.
prostacyclin analogs. Okay, Presentan, sildenafil, and iloprost and epoprostenol. Shortness of breath, cough, fever, experiencing mild upper respiratory illness. He has a history of asthma and use inhaled bronchodilators. The cough, blood pressure is 90/60. Pulse and respiration, then the patient appears to have. So he is asking why we are using ketamine in this, specifically in this patient. What is the benefit of ketamine in this patient for giving anesthesia? The patient is suffering from low blood pressure and also from asthma attack. Okay, so we know. Let's see the effects of ketamine. So page number neurology, I guess. Ketamine. Ketamine intravenous anesthetic. Main function is it can also cause, it is also sympathetomimetic. Okay, and as a sympathetic nervous system's a function is increase the blood pressure, increase the heart rate, increase the bronchodilation. Our patient is suffering from low blood pressure. That issue is going to get solved due to ketamine. Our patient has bronchoconstriction. That is also going to get solved due to ketamine. Okay, that's why we are using ketamine in this specific scenario. Okay, so what will be the answer here? Sympathomimetic activity.
E.
Okay, it preserves the symptom bronchodilation, which is also. We have this question is also done before. This effect is called permissive effect.
Permissive.
Okay, that the steroids increase the responsiveness of receptors to the catecholamines. Okay, so if you are using steroids, the catecholamines have a much higher effect. Okay, they will able to perform at their full in the presence of a steroids. Okay, this is called permissive effect. It is written in General Pharma. Okay, let me show you. So some people who have not seen this where it is written, they will get an idea. Permissive effect. Presence of substance A is required for the full effects of substance B. Cortisol and catecholamine responsiveness. Okay. Hmm. Muscle relaxant X is most likely to be which of the following medications? 63-year-old man is hospitalized. Give me a minute. Okay, do you know what is this test name is? What is the name of this test? What is happening in this photo? It is called train of force stimulation test. Okay, it is used during anesthesia to assess the degree of paralysis induced by the neuromuscular junction blocking agent, the muscular relaxant. Okay, what we do in this test is that the peripheral nerve is stimulated 4 times in quick succession, and the muscular response is recorded. The height of each bar represents the strength of each twitch. Higher bars indicate the activation of an increasing number of individual muscle. Okay, when a depolarizing neuromuscular junction blocker is used, competitive inhibition of the postsynaptic receptors at the motor end plates prevents some of the fibers from activating, decreasing the strength of the twitch. That's why you can see that the height of the patient's initial response is is lower than the normal. Okay, but you can also see that after 30 minutes there is a progressive reduction in there's a fading pattern as a result of less acetylcholine being released with each subsequent impulse. Okay, this is what we seen in non-depolarizing neuromuscular junction blockers. In contrast, when a depolarizing is used, initial function is initially function by preventing the repolarization and shows a equal reduction of all 4 twitches. Okay, and after some time you are going to see a persistence. You are going to see a fading response. Okay, in the if there is only the third photo is available, that means it is a non-depolarizing neuromuscular junction blocker. If the patient show first the initial response, there is equal reduction, then there is like a fading response, then that is a depolarizing junction blocker. Okay. Now we have to find out which one is a depolarizing junction blocker. Okay. For this we have to first we have to find which one is depolarizing. Anesthetic, local anesthetics. Benzocaine, cocaine, tetracaine, bupivacaine, pilocaine, ropivacaine. These are local anesthetics. Okay. These are not depolarizing. Here it is. Here it is. The depolarizing neuromuscular junction blocker is succinylcholine. And the non-depolarizing are etracuronium, cistracuronium, rucuronium, and vicrocuronium. Okay, so you have to tell me which one is depolarizing here. Depolarizing.
D.
Succinylcholine is the depolarizing one. Okay.
I did not understand, doctor.
Okay, whenever you are
Me
using
either.
non-depolarizing blockers, you are going to see a fading response. In this test, we stimulate the muscle by stimulating the nerve. Okay, and the height of each bar, we stimulate the muscle 4 times. Okay, and the strength of the construction represents the height. Okay, in the depolarizing one, in the non-depolarizing one, we are going to see a fading response only. Okay, but in the depolarizing blockers, you are going to first see a constant diminished response, and after that you are going to see you are going to see the same response as the one you have seen in the non-depolarizing one.
So why is it constant initially?
That because it is constant initially because it causes it is due to the phase 1 blockade. it causes the prolonged depolarization during that phase. Okay, but after some time, it is acting and the same mechanism of action as the non-depolarizing is acting. Okay. Okay, I will try to explain this in a much greater detail in the next lecture. Okay, I
Okay,
will
thank you.
I
Thank
will
you.
write this down and try to explain this in a greater detail. Okay,
Thank you. Yeah.
why it is three, or I will send you a voice note in the group. Okay, explaining this question. Okay,
Yes, that
Okay.
will be great. Thank you.
after the lecture, I will send a voice note and a diagram as well, explaining all the algorithm. Okay. 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 Which of these drugs bind to the beta 2 receptor? Which of these drugs bind to beta 2 receptors?
Albuterol and salmeterol.
And lev albuterol as well. These two does not bind to the beta 2 receptors. Okay. Okay. Albuterol, salmeterol, and formoterol. These are beta 2 agonists. What is the difference between albuterol and salmeterol and formoterol?
Albuterol is short acting and salmeterol is long acting.
And it is long acting. Okay. Okay. So now you have to tell me the drug we are discussing in this question, is it a long acting one or is it a short acting one?
I think short
Short
acting.
acting. Mhm.
It is short acting or long acting?
Long acting.
It is long acting one. And we know which one is the long acting one?
Salmeterol.
Salmeterol.
Metro.
Okay. Because it is it has a lipophilic side chain, and when the drug has a high lipophilicity, it will bound to the plasma membrane for a longer period. Okay, because like dissolves in like, and plasma membrane also have lipophilic component. Okay, and if it is hydrophilic like albuterol, it will bound for a smaller time period. Okay.
Okay.
We have also done this question before. What is the answer for this question?
Let's see.
Genetic polymorphism. We have solved this question before. Okay. Okay. What will be the answer for this one? The timodate as compared to propofol. Okay, so he is asking us why we are preferring timodate over propofol in this patient. Okay, our patient is hypotensive. Okay, remember this detail. Timodate. Its side effect can be acute adrenal insufficiency, hemodynamically neutral. Okay, it is a hemodynamically neutral. It does not causes decrease in blood pressure. Okay, because it is a hemodynamically neutral. It will keep the blood pressure normal. Okay, it will keep the heart rate normal. Okay, that's why we are using a timodate here. Okay, and the propofol decreases the blood pressure. Okay, propofol decreases the blood pressure, and we know in this question that the patient is already hypotensive. Okay, so we should use a drug which should be hemodynamically neutral. So what is going to be the answer here?
D.
D. No cardiovascular depressant effect. Okay, propofol has a depressant effect. Okay, and and ketamine has a activating effect. It will increase the blood pressure. Ketamine. What is the diagnosis here?
Obstructive lung disease.
Which one? Which one? Is it emphysema? Is it COPD? Is it asthma? Which one?
I think it's emphysema, but it's 32 years and penicillin.
Then how it can be emphysema?
Yeah.
What is damaged here? Bronchial
Yes.
wall is damaged here. There is cellular infiltration of the bronchial wall. Emphysema affects the alveoli. Emphysema does not affect the bronchial wall. It affects the alveoli. Okay, the distal alveoli. Okay, and we are also seeing airway mucus plugging. Mucus plugging is seen in which disease?
Asthma.
Asthma. Mucus plugging is seen in
Asthma.
asthma.
Pancreatitis.
Mucus plugging is seen in asthma. Asthma, mucus plugging. Okay, it is a specific symptom of asthma. Okay, it is asthma. Long-term use of which of the following drug would have best prevented this? Which one should be the answer?
Me?
Is it going to, it is? Which option did you say? The
Fluticasone.
steroids. Steroids are the ones which act as a long-acting one. Okay, steroids are the only albuterol. Albuterol is only for the sympathetic relief. Okay,
Short acting.
propium is used in COPD. Quantica can be used, but and theophylline is no longer used. Magnesium sulfate is also usually not is rarely used. Okay, it is only used in emergency condition. Okay, so the only option we left with fluticasone. First line for therapy for chronic asthma. Okay, albuterol is only for acute symptoms. Okay, which of the following effector cells are primarily responsible for immunological control in this patient infection? Okay, what is the diagnosis in this question?
Latent TB.
Primary tuberculosis.
Yes, TB. Okay, okay. What type of cells are involved in the granuloma formation? In the granuloma formation,
Macrophages.
T cell,
which cells are involved?
T,
CD4 T lymphocytes and macrophages.
Okay, which type of T lymphocytes? TH1 or TH2?
TH1.
TH1. Okay, so we know that, and there is no role of antibodies in this, right? Option A and D are eliminated, and we know that there are CD4 cells, not the CD8 cytotoxic cells, right? So we are left with option B and C. And we know that they are epithelioid cells and multinucleated giant cells, right? And the multinucleated giant cells and epithelioid cells are formed from where? They are formed from macrophages. After the TSCD4 cells release what? Interferon gamma. After they released interferon gamma, there is no role of interneutrophils in there. Okay. See this. First, there is release of interleukin 12, which converts TH1. In TH1, release interferon gamma. Interferon gamma causes the activation, and after the activation, they form the epithelioid cells or giant cells. Okay. 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 So, what is happening in this patient? There is thick pleural effusion here, right? Which has separate fluid pockets within the pleural space. And there's a moderate side loculated pleural effusion. There are tube placement produces only a small amount of thick pus. So what we need to do in this patient is how we can how we can improve the drainage through chest tube. Okay, to improve the drainage, what do we need to do here? Is to convert the pus from thick to thin, right? And how can we convert the pus from thick to thin? Okay, we have done this question before,
Yes.
and the answer for this is
Activation of fibrin bound plasminogen.
okay, because it will break the fibrosis there. The plasmin is going to get activated, and that plasmin is going to destroy the fibrosis there, which will causes the its secretions to become thin as compared to thick, and it will increase the drainage. Okay. There's organized fibrosis there, and fibrinolytic agent can improve the drainage. Okay, hemoglobin are most likely to be released. Which of the following? 0.1 to 0.2. Oxygen saturation increases 50 to 100%. Okay. Which of the following is going to be released from the oxy from the hemoglobin molecule from low oxygen saturation to higher oxygen saturation?
Is it phosphate?
Protons.
Phosphate.
Mhm.
It's
We know that
phosphate.
for phosphate
Chloride.
has no roles. Yes, let's see. We know that B and D are not the right answer, right? Because these are the two things which are not released by the hemoglobin. We are left with chloride, oxygen, and proton. Okay, and we are seeing that oxygen saturation is increasing from 50 to 100%. Okay, from 0.1 to 0.2. So that means it is taking the oxygen, not releasing it, right?
Yeah.
So point C is not the answer. Okay, now we are left with A and E. So do you know chloride shift?
Yes.
What is chloride shift?
With HCl3.
Does venous blood RBCs has more chloride or the arterial blood? Which one has more chloride? Okay, let's see.
Is it Venus?
Hmm?
Venus has more chloride? I'm not sure.
Why?
Venus will be like acidic picture, more CO2. There is, I think, carbon dioxide and chloride is like shifting one another.
Okay, so right shift in oxygen diffusion curve, decreased hemoglobin affinity for oxygen, occurs with increased excess, decreased pH, increased temperature. Okay. So we are seeing that there is increased oxygen saturation from 0.1 to 2, right? So that means that there is increased unloading of oxygen, right? From 0.1 to 0.2, right? And increased unloading of oxygen occurs when there is decreased pH, increased temperature, increased hypoxia, increased a increased hypoxia, increased metabolism, increased carbon dioxide. All of these are going to cause the increased oxygen unloading. It will going to cause the right shift, right?
Yes.
Okay. And we are seeing at point 2, the oxygen saturation is increased, right? It will increase the oxygen binding capacity. Okay. So that the more oxygen is bound to the hemoglobin. Okay. So to bound more oxygen, he is going to release what? Protons. It will make to, okay.
I did
Because
not understand the question.
It's
Oxygen loading or oxygen unloading? Did not understand the question. What they want.
Oxygen release, it means pH is going to be reduced. It's going to favor oxygen release. Acidity
Yeah,
reduce.
yeah,
Yeah,
it's there. But in this graph shows what? Like oxygen loading or oxygen unloading?
I, I think so it is showing oxygen loading.
Yeah, it's showing loading.
It is
It
showing
is
oxygen
increasing.
loading.
Okay,
Yes.
they are asking as you go from 1 to 2.
Yes.
Okay, okay, so towards 2. Okay.
Okay. So we have to remove the protons. Okay.
No need for energy at this point. No, we're not using energy.
It will increase the oxygen binding affinity. Okay. Haldane effect. Okay. The acidity of the hemoglobin molecule is increased in response to protons are released from the hemoglobin binding sites.
Right. Hmm.
So that's why the affinity is increased at point 2, and that's why the oxygen saturation is increased because we are removing the hydrogen ions from there. The pH is going to increase and the acidity is going to decrease there. Okay. The regenerated cells are most likely derived from which type of cellular types?
It's F.
No, type 1.
Which of the cells are involved in regeneration?
Type 2 pneumocyte.
2.
Type 2 pneumocytes serve as a stem cell precursor for 2 cell types proliferate during the lung damage. Type 2. Okay. Okay, first try to diagnose the patient. The patient is 41-year-old, 3 weeks of low-grade fever, productive cough, weight loss. Drinks beer how many times? 10 to 12 beers a day. Okay. He appears poor dentation and clubbing of the fingers also noted. Foul smelling sputum. Foul smelling sputum. Okay. Whenever you heard the word foul smelling, which bacteria that should come inside your head?
Anaerobic.
Anaerobic.
And anaerobic. Okay.
Oops.
Okay. The patient has clubbing of the fingers. We know clubbing of the fingers occurs in which diseases? Clubbing of the fingers.
Saturated lung disease.
Lung cancer, idiopathic pulmonary fibrosis, cystic fibrosis, bronchiectasis, lung abscess.
Lung abscess.
Okay. Okay. Whenever you heard the word foul smelling, first thing that should always come in your mind, it should be anaerobics and anaerobes. Okay. Okay. Can anyone explain me in this X-ray, in this CT scan, what what are you seeing in this CT scan? Can anyone explain the CT here?
Some mass is actually showing in the lung area, like
Yes, okay. So
on
some
the
type
right
of
side.
fluid is showing. There's a opacity on the back. There's a fluid at the back. And within that fluid, you can see there's a black areas. Okay, black area represent what? Air, right? There is some air.
Yes.
Yes. There is some air within that fluid area. So we call this air fluid levels. Okay, and air fluid levels are seen in what?
cause in absence.
Lung abscess.
Can you please zoom the airflow level?
This blackish area
Black
within
ridge
the
area.
the black circles, because air represented as black. Okay,
Black.
blackish areas are the air, and the all the surrounding area is fluid. Okay, so the diagnosis here is lung abscess. Okay, and in lung abscess, what type of bacteria are involved? Aerobic or anaerobic? What type of bacteria are involved?
I think both of them.
These are anaerobe
Anaerobe.
plus aerobes.
Yes. Lung abscess is a polymicrobial infection. Remember this. It is a polymicrobial. Whenever you are going to give treatment for lung abscess, always give a drug which includes both aerobes plus anaerobes. Okay? See, idiopathic pulmonary fibrosis, lung abscess. See, infections, lung abscess. Our patient has digital clubbing as well.
Clubbing. Yeah.
Okay, lung abscess. Due to anaerobes or staph aureus, air fluid levels can be seen. Localized collection of pus within parenchyma caused by aspiration. What is the cause of lung abscess in our patient? He was drinking 10
Aspiration.
to
He's
12 beers
Drinking,
a day.
drinking.
Yeah,
10 to 12
10
bottles
to
of beer.
12 beers a day. A day. That's why he has poor dentation and clubbing. Okay. Okay. What should be the answer here?
E.
E.
Aerobic plus anaerobic. Air fluid levels. Okay. Diagnosis in our patient.
Asthma.
Asthma. Very good.
Mm.
Does we use dextromethorphan for asthma?
No.
No. Okay. Ipratropium?
COPD.
Yeah, okay. We are left with these four options. Okay. What is the at what place does steroids act? Steroids act at what location?
Nucleus.
Within the nucleus. Okay. They do not inhibit the interaction of inflammatory mediators by cell surface receptors. They have nothing to do with cell surface receptors, right? Okay. How does albuterol works? It acts on where? Beta 2 receptors, right? It has also
Yes.
nothing to do with inflammatory mediators. Okay, we are left with option E and option F. Now you have to tell me what is the a mechanism of action of montelukast and xylitol.
A.
What is the mechanism of action of E and F?
Montelukast was against your leukotriene receptors,
Yes.
and xyloton.
We have
The
just said
5-lipoxygenase
It's
degranulation
inhibitors.
is stopped by which degranulation?
Declination is stopped by
Chromoly
chromoly.
and Montelukast act blocks the receptor, and xylitol stops the production of the inflammatory mediators. Okay. So in this, he is asking the one who blocks the receptors. So the answer is going to be Montelukast. Okay. And the one which stops the production of inflammatory mediators is xylitol. Okay. Okay. IgE is involved in which disease? In which respiratory disease?
Asthma.
Asthma.
Asthma. Airway collagen deposition occurs in which disease? Collagen.
Is
Collagen
it
deposition
fibrosis?
occurs in
Fibrosis.
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 Fibrosis or something.
Alveolar destruction occurs in which disease?
Emphysema.
Emphysema.
Emphysema. Pulmonary vasodilation. In which disease we are going to see vasoconstriction? Pulmonary.
Vasoconstriction is the
Pulmonary
pulmonary
hypertension.
Pulmonary
hypertension.
hypertension. Okay, we are left with B and D. Which one is going to be the right answer here?
I'll go from
I think
D.
B.
B. Decreasing airway.
Mhm.
Okay. Decreasing airway. And the drug we are talking about here is
Omalizumab.
omalizumab.
Yeah.
And option D represent which drugs? Albuterol. Okay. We are talking about omalizumab. It will bounce the mostly unbound serum IgE and blocks their receptor using asthma with increased IgE levels resistant to inhaled glucocorticoids and long-acting beta-2 agonists. Okay. Hmm. To treat the protein misfolding disorder. Misfolding disorder.
Cystic fibrosis.
So in which of these disease you are going to see a protein misfolding disorder? We have just covered that specific topic. In which disease you are going to
Cystic,
see a
cystic
protein
fibrosis.
misfolding disorder? Cystic
Fibrosis.
cystic fibrosis. Okay, so the drug that we are going to use in this patient that is going to improve this condition would be helpful in cystic fibrosis. Okay. Mm. What is the age? 19-year-old. 3 episodes of pneumonia. Yes, celiac disease as well. Facial swelling, generalized hives, and shortness of breath. Eh, Do you think option number A is the answer?
No,
No.
No.
it's all
No.
negative. Like, so
Yes,
no.
option
No.
number A is not the answer, because then how are you going to explain that the patient has 3 episodes of pneumonia and celiac disease and everything? Okay, so A is not the cause here.
D
Okay.
is G.
Do you think E is the right answer? Skid.
No.
No.
No,
No.
because kid patient usually dies at a much early age.
Earlier, yes.
It is a
Early.
very severe disease, and patient usually dies at 2-3 years of age. Okay, this patient is 19-year-old woman. Okay, we are left with three options: C1 inhibitor deficiency, leukocyte adhesion deficiency, and selective IgE. Do you think C1 inhibitor deficiency is the answer?
No.
No.
C1 inhibitor deficiency causes hereditary angioedema.
Hereditary angioedema, yes.
Okay, and we can see there it is not related to angioedema. We are clearly seeing that the patient has infections and there is celiac disease and there is response to blood transfusion. Okay, so it is either C and it is either D. This we have to go. Selective IgA deficiency, most common primary immunodeficiency. Majority asymptomatic, airway and GI infections. Our patient has 3 episodes of pneumonia. Atopy, autoimmune, anaphylaxis to IgA in blood products. Our person receives blood products, and after blood products there is anaphylaxis. So that can also be explained by selective IgA deficiency. Okay. And celiac disease, autoimmune disease are also common in selective IgE. Okay, so the right answer is
D.
selective IgE. That's why the patient has facial swelling, generalized hives, and shortness of breath. That is due to the anaphylaxis reaction to the blood products. Okay, which occurs in selective IgA deficiency. Autoimmune diseases usually asymptomatic. So we have done this question before, that which of the following smoking cessation drug can reduce the nicotine craving?
Penicillin.
Then the answer is
E.
vermicycline, not nicotine patch. Remember this? This is written at vermicycline help nicotine cravings, diminishing affect the reward system, but also reduce the withdrawal. Okay, so vermicycline is the right answer in this question. Okay. What's the diagnosis here? What test we need to do to confirm the patient in this case? Yes, and to confirm that the patient has asthma, because the pulmonary function testings are normal. Okay, so when you have a when the because pulmonary function testing will be abnormal only when the patient is having that act. Okay, so in those cases, to confirm that it is asthma, we use one more test, methacholine challenge test.
Challenge.
Methacholine challenge test. Okay, obstructive pattern with bronchodilator response, but may be normal when not in exacerbation. Okay, when it is not in exacerbation, PFTs can be normal. And when they are normal, we use what test? Methacholine challenge test. Methacholine is same like acetylcholine, and it is going to cause constriction. And we are going to measure how much constriction it is going to cause, whether the bronchi are hyper responsive or not. Okay, if they are hyper responsive, that means the patient has asthma. Okay. Okay, we have to tell which one of the following thing in the elastin fiber Paul allow the property of elastin to be stretchy. Okay, what causes elastin fibers to be elastic? Okay,
It's B.
it is B.
B. Yeah, somebody.
Chain assembly to form a triple helix. There is triple helix here, but is the triple helix is the cause of the elasticity? Okay, disulfide bridges are formed in collagen. They are not formed in elastin.
Hmm.
Okay. Okay. And triple helix is also formed in collagen, I think. So it is not formed in elastin, right? Does triple elastin form triple helix formed in collagen or elastin?
Not
That's
confirmed.
Collagen synthesis and
Collagen
osteogenesis
synthesis.
imperfecta can be occur.
so does not occur in elastin. Let's see where it is written at page number. Okay, triple helix formation occurs in collagen, not in elastin. Okay.
Okay.
Okay. The hydroxylation occurs in what? Heavy post-translation hydroxylation is also occur in collagen. Where is the elastin? Okay. See. Cross-linking occur extracellularly while lysyl oxidase and give elastin its elastic properties. Okay, so the answer is cross-linking due to lysine. Okay. the cross linking. Okay. What are the abnormal things mentioned in this question? Signs and symptoms in this question.
Pulmonary pressure is high, so pulmonary hypertension.
Yes. The mean pulmonary arterial pressure is high. Okay. There is no evidence of the what group A, what type of pulmonary hypertension is it? It is. Patient age is 37-year-old woman.
Type 1.
Type
Primary
1.
type 1.
Type 1. There is no evidence of obstructive lung disease, interstitial. This type 1. Okay. So what type of pharmacotherapy we used a pharmacotherapy for three products. One is phosphodiesterase 5, other is a prostacyclin analog, and the first one is
Endothelin antagonist.
And they tell
Mm.
see.
endothelin antagonist. See the options. Chronic cough, progressive weight loss. Patient is from Southeast Asia. Okay. He has lost 5 kg. Okay. Just apical left lung infiltrate. On gram stain, you have, and culture does not show anything. Okay. Culture goes acid fast bacilli. Which one is acid fast bacilli?
Tuberculosis.
TB. TB.
TB. The patient has TB. The patient is from Southeast Asia. The patient has a apical left lung, which means it is a reactivated TB, has weight loss, chronic cough. Okay. So on the histology, the thing you are seeing, what it is?
Like
Granuloma.
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 Is it a granuloma or is it a
Caseating granuloma.
Giant cells.
Giant cells.
giant cell?
giant cell.
It is a
Elymoid.
multinucleated giant cell, right? Okay. What is involved in multinucleated giant cell? Which
Macrophages.
macrophages are involved? Okay. Okay. First, let's eliminate the option. B lymphocytes are not involved in the granuloma formation. Fibroblasts are not. They are involved in fibrosis. Neutrophil are also not involved. CD4s are involved. CD8 T cells are not involved. Right? CD4 T cells secrete what?
Yes.
CD4 T cells secrete what? Interferon gamma.
Interferon gamma.
Gamma.
Yeah.
And that is going to cause the change in the cell from a macrophage into the giant cell, multinucleated giant cell. And this is a multinucleated giant cell. You can see that it has many nucleus. Okay. So very good. It is a multinucleated giant cell. Use of dextromethorphan is most concerning for which other? "39-year-old woman, nagging cough. 2 week ago had upper mild respiratory illness which resolved spontaneously after several months. Since then, she has had cough that is productive of minimal placed sputum, shortness of breath or chest pain. Other medical condition is major depression, for which she takes sertraline, okay, which is a SSRI, right?
Yes.
Okay, she does not use tobacco, alcohol, illicit drugs. Vital and physical shows no. Okay. So do you people know the side effects of dextromethorphan?
No.
Okay. Very good.
Mm.
Okay. Okay. Has mild opioid effect when used in excess. Mild abuse for potential. May cause serotonin syndrome if combined with other serotonergic agents. Okay. Is our patient is using any other serotonergic agent?
Sertraline.
Naturally.
Certainly, it is
Yes.
a
Yes.
SSRI.
Mm.
It is a serotonin receptor uptake blocker. Okay, so it is going to increase the serotonin levels. Serotonin syndrome. Any drugs that increases the serotonin levels. SSRIs, SNRIs, vortioxetine, busulfan, and in this you can see the non-dextromethorphan. Never combine these drugs. Okay, when you're going to combine these drugs, there is a chance of serotonin toxicity. Okay, it is written in psychiatry. Okay, what would be the answer here?
B.
Drug interaction.
Yes. Okay. You first solve the last question, then we will come here. Which of the following is more for driving the development of the patient observed microscopic lesion? Mm. Okay, what is the diagnosis here? 64-year-old man, persistent cough, fever, weight loss. Pack of cigarettes, left upper lobe. Left upper lobe, there's an infiltrate. Most likely some infection, but on gram stain, we do not found any organism. Okay, it is an infection, but that is not a bacterial, that it is a type of infection which cannot be stained on gram stain. Okay, the patient is prescribed both antibiotic for community acquired pneumonia and aspiration pneumonia, but symptoms worsen despite taking the medication. That means that it is not an aerobic bacteria or an anaerobic bacteria. Okay, okay. In the photo, can you tell me what is visible in the photo? What can you find in the photo?
Giant cells.
There is a multinucleated giant cell in the center of the photo. Okay, and the diagnosis here is
TB.
Tuberculosis.
yes, the diagnosis is TB. That's why it is not found in the gram stain, and that antibiotics are no longer helpful in treating the patient. Okay. Which one is going to be the substance cytokine which is involved in TB?
Gamma, interferon gamma.
Yes, IGRA interferon gamma. Okay, let's come to this. Last question. The study drug is most similar to which of the following medications? Okay. Okay, can anyone explain me the graph, what is happening in the graph? Okay, so there are 4 lines in the graph. Okay, first come to the graph number 1. In graph number 1, the black line represent that when you give the irritant, you will see bronchoconstriction, and with the time, the diameter decreases. Okay, now what is the function of a parasympathetic nervous system? Does it cause bronchodilation or bronchoconstriction? Parasympathetic.
Dilation.
Bronchoconstriction.
Yes.
No,
Dilation.
No, I think it's dilation. You said
it's dilation.
Parasympathetic is bronchoconstriction.
Constriction, not
Yes.
dilation.
Yes.
Constriction and secretion.
Okay. Parasympathetic.
Is it parasympathetic?
Yes.
Okay.
Because there's constriction going on.
Parasympathetic causes parasympathetic, and this sympathetic, which is the fight or flight response. Like if you see a lion right in front of you, how will your body respond to that? Your body will respond to that by dilating the bronchus, so you have large amount of air inside your lungs, so you can supply large amount of oxygen to your muscles, and so your body can respond to that at a much more efficiently. Okay. Okay, so in parasympathetic, your bronchus will going to be constrict, and and the green line in the first graph, when we cut off the vagus nerve, we are seeing there is a even after adding the irritant, the bronchus diameter does not shrink, right? There is still bronchodilation. Okay, after when you cut the parasympathetic nervous system, you are going to see bronchodilation. That's why when you add the irritant, the bronchus does not constrict. Okay, now comes to the other graph. There are 2 lines again in the second graph. In the second graph, the green lines act. The green line is the same like in the first graph, that you have cut off the vagus nerve and you are seeing bronchodilation. Okay, but the other thing is that right in the graph, you also add a drug as well. Okay, and you can see that when you did not do the post vagotomy and you add only the drug, you will see bronchodilation. Okay, but when you did the when you cut off the vagus nerve, and then you will still see the bronchodilation, but that bronchodilation will be the same as the one which you gives without the vagus nerve and only with the drug. Okay, adding the drug in a post-vagotomy patient will not have any effect in the bronchodilation. Why is that? Why, when you add drug in a post-vagotomy patient, there is no increase in bronchodilation? That means the only reason that can explain this finding is that the drug is acting through the parasympathetic nervous system, right? That's why when you have cut off the parasympathetic nervous system, the adding the drug will not have any effect. Okay, the green lines in both the graph are similar. You can clearly see. That's why adding the drug will not have any effect on the bronchodilation when you have cut off the vagus nerve, because the drug is acting through parasympathetic nervous system. It is blocking the parasympathetic nervous system, causing bronchodilation. Okay, so
So
what?
it's behaving like a vagotomy, correct?
Yes, it is behaving like a vagotomy.
Okay. Yeah.
So which drugs behaves like a vagotomy? Which drug is anti-parasympathetic symptom? Which drug is anti-parasympathetic symptom?
Ipratropium?
Ipratropium is anti-parasympathetic nervous.
Yes.
Albuterol acts at what receptor? Sympathetic nervous
Beta
system
two.
receptor beta 2.
agonist.
Beta
Okay.
2.
Okay. Theophylline acts on increasing cyclic CMP levels. Xylotine acts on leukotrienes. Nifedipine has nothing to do with bronchodilation and constriction. Okay, so the only options that is making sense is ipratropium. Okay. Ipratropium blocks the muscarinic receptors. Muscarinic receptor preventing a bronchoconstriction. Muscarinic receptors are the receptors of parasympathetic nervous system. Okay. So this is all for today. Tomorrow we will do a micro of pulmonology. Okay, I will send you the topics. Okay, there like you have only to read 3 to 5 pages. If you cover those 3 to 5 pages, your micro of pulmonology will be covered. Okay, I will tell you which specific bugs you should come prepared with. Okay.
Okay. Okay. And Doc, can
Okay,
you
Doc.
please send the recorded video almost immediately?
Actually, sending the recording is Dr. Ahmed and Dr. Hamza's work. I don't know how they do it. I will ask them to send the recording immediately. Okay.
Yes, because sometimes it takes a while. Please tell them to send it
Okay.
almost immediately. Thank you.
Okay. Bye bye.